Thank you very much. Thank you for letting me be a part of this lovely program and for giving me this interesting topic to talk about. Today, I've been asked to talk about the preoperative considerations or the planning considerations for endovascular repair of chronic type B dissection. And I think it's important to remember that we meet these patients very early on, but by the time they become a chronic aortic disease, it's really more of an aneurysm with a luminal blockage that we're dealing with. So it comes with a lot of different complex considerations. But there's no question that even if we manage people medically through the early stages or place a TVAR in the middle stages, at some point, and usually within about 10 years, people are going to need a reoperation. And it's far more likely the longer they survive that that operation is going to be necessary. And as they get more advanced in years, endovascular options become more appealing because they are minimally invasive. The challenge of chronic dissections is the fact that there are so many other considerations besides just the aortic disease itself, the fragile landing zones, the variable origins of visceral vessels, and the constrained true lumen, all of which cause some problems for endovascular repair. So when I think about planning a chronic type B dissection case, I don't just think about what the images look like preoperatively. I also try and come up with a plan for my intraoperative considerations, as well as what I'm going to do postoperatively when the inevitable endoleaks and false lumen perfusion continues. And so it's in these three different categories that I've decided to break down a case just to take you through how we do things at the Royal Free in London. This is the case of a 60-year-old woman who presented originally with an acute type A dissection. And she had a frozen elephant trunk placed by the cardiac surgeons. And you can see she's come to me now with a chronic type B dissection and an expanding thoracic component. We placed a TVAR down to the celiac, but there's no question that further treatment was going to be needed. Make note of the fact that this left kidney is actually quite small and malperfused and comes off the false lumen. When I look at these images in axial section, and it's really important to have good post-processing software when you're looking at cases like this. It's important to draw a center line of flow just like you would for a normal thoracic or thoracoabdominal aneurysm. But in this case, as I'm going down and looking through, I'm also paying attention to where the origins of the vessels are coming from, how complex the dissection is, how large the lumen is, and then I routinely readjust the center line so that it follows the path of the true lumen. Even though this doesn't give us perfect perpendicular images, it actually gives us a much better idea of what the ultimate perioperative or graft plan will look like. And you can see here in cross-section, when we have our center line going through the true lumen, we're able to better understand the degree of thrombus in the false lumen, as well as where all the branch vessels are and whatever hurdles there might be intraoperatively. Once that's done, you can place the relative positions of the branch vessels in the usual way, going up into your landing zone, whatever you choose it to be. In this case, we made the decision not to stent the left renal because the kidney was already quite small. It was going to be very difficult to cross the septum, and we felt that this was not worthwhile in this patient's best interest. So the graft plan that we ultimately came up with, you'll notice, has a narrow main body, but I'll draw your attention to the fact that it's actually 26 millimeters in diameter, which is much larger than the true lumen that the patient presented with. But I had confidence over time it would expand, and I wanted to leave her with a normal aorta. At the end of the day, I also did everything I could to make sure that this was an easy case. I preloaded all the catheters, I made it double diameter reducing tries to try and reduce the luminal dimensions, and I made it in a low profile fabric. The surgery itself is much easier if you have a hybrid suite and you have advanced imaging technology in your suite. We're a poor hospital, so we have only this very basic fusion, but we do use fusion imaging as much as possible. And just in case it fails, I routinely go through and mark the vessels, at least 2 of the vessels, with catheters so that we have a bailout if something horrible to happen. God forbid we could place a chimney or something into the renal artery and the SMA to bail ourselves out. While doing this, it also gives me a better idea of what the angles are for any given vessel, and it allows us to better plan how we're going to get into the vessels once the graft is in place. And you can see getting into the SMA here, it does take a little bit of time to get the catheter to come around this very steep angulation. But once it's in, it gives us a really nice fixed position for bailout if we need it. Also note how constrained everything is within the true lumen. When the device is in place, I go to great pains to make sure that it's properly oriented by constantly moving the II back and forth to ensure that our vessels are in the right condition. And then in this particular case, because the true lumen was so constrained, we decided to stent in a very staged way. So you notice that the graft, the main body, is still constrained, and yet we're taking the time to get the celiac artery and then in succession the SMA and the right renal artery before the graft is fully opened. This gives us the ability to, and as you'll notice it's happening, gives us the ability to actually twist the graft intraoperatively if we need to line up each fenestration individually in a far more defined way. The preloaded catheters also are a huge help in terms of making sure we're oriented outside of the fenestration and getting access much faster. Now, there was a significant amount of video editing to make it go that fast. So the intraoperative considerations are definitely confirming your lumen, use IVUS to make sure you're in the right place, and then go very slowly and make sure you have bailout plans over the course of the rest of the procedure. Thank you very much.